Let's talk about a myocardial infarction. What is a myocardial infarction? So your heart, I got you. Your heart muscle is not getting blood flow, so that too, and it is dying. Well, your heart has to pump to, yep, to live. And once that heart muscle is dead, that portion of the heart muscle is dead, can it come back to life? No. So what does it form in its place? Scar tissue. What are the two things about scar tissue that you're like, oh no? Okay, it does not conduct electricity, which that's a problem. You have to have electricity in your heart for it to beat. And then what's the second thing you said? It doesn't stretch. That's bad too because your heart goes bim bim. Yes. All right, so we have a problem. All right, now what is did I do this right? Yeah. All right, so we said an MI is ischemia to the heart muscle. It is dying, so it is screaming and it is telling you, ouch. Yes? Okay. You'll know the symptoms in men and women. It is very different. Okay. And how do you know the difference between unstable MI? Unstable angina versus an MI? But so is unstable. But if it
dies,
what?
if it dies,
If what dies?
if the tissue dies.
Well, that would be bad. But how would we know that? We're going to have to do a full cardiac workup. So that's why when a person comes into the hospital and says, I have chest pain, we're like, I got you. And I got 60 minutes to get you to cardiac cath, right? Otherwise, how would we know? Because it's persistent chest pain. Yeah. All right. So symptoms in men, y'all know what this looks like because it's typical. This is what they always taught us. This is what it looks like. Okay. Then all these women were dying and they're like, this is baffling. I wonder why. Yeah, because we're different. Okay. We're not made the same. All right. So in men, you'll see cold sweats. They'll go into crushing chest pain. They said it feels like a elephant sitting on your chest. Dyspnea. They get tingling in the left arm. Y'all know all these because they're we've seen this a million times. Okay. Some of them may say my stomach hurts. They mean like that's your chest, boo boo. Okay. A lot of them feel very nauseated. They're dizzy, and then it usually lasts over 20 minutes. Now, just because their pain resolves does not mean it was unstable. It could have just been like, oh, well, we done our damage, and right. So you still have to do a workup even if the pain is resolving as you're in the ER. Okay. Because either if the pain is resolving, you could either be like, well, we lived, or you could be like, yeah. Well, it's kind of like whenever they come in with right lower quadrant pain, severe, 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 and then they're like, oh, it doesn't hurt anymore. And you're like, oh my God, I healed you. Wait, no, your appendix is rotting. Yeah, it has ruptured and it is rotting. All right. In women, the number one sign is fatigue. They have an overwhelming fatigue. So every day I feel like I'm having an MI. That's not funny, don't laugh. Okay. So dizziness. They have upper back pressure or like shoulder. They may say shoulder pain, right? Chest pressure, dyspnea. They often will complain of jaw pain or neck pain, which is kind of bizarre. Or they may say like my boob hurts, like not like underneath the boob, like my actual like boob hurts. Okay. Nausea, vomiting, or some of them are like, I can't sit still. Like they feel kind of, right? Pallor, weakness, those I can kind of expect. All right. But in women, it just looks different and they may never have chest pain.
None of this screams. You
Am I?
list, and I still wouldn't pick
Yeah, if you're just like, oh, my jaw feels weird. I'm like, oh, that's so crazy. Is your toothache? Yeah, I know we do. I do that. Oh, this side is like way bigger than this side. I don't know what's wrong with me. I know I do it. I think I do it at nighttime all because when I wake up, my hands are sore, like open, like this. I'm like, yeah, okay. I don't know. Anyhow, so we understand in women it's different. Yeah. All right. So they come into the hospital. We got to do a full cardiac workup. Turn your papers over because all y'all doing is staring at your papers. Thank you so much. Okay. Let's just say you just bring the patient comes in, they go up to triage and they're like, my chest hurts. What are you going to do? Okay. So I will sit them upright. Okay. You can ask. Yes. I'm going to sit them upright. Right. You're always going to pick position. Okay. So I'm going to put them on an EKG. All right. The EKG is normal. What do? Could they still be having a heart attack with a normal EKG?
Yes.
Absolutely. The EKG, and now if it's a STEMI, I'm like, oh, okay, but it doesn't tell me much. They could have had a heart attack that just resolved. They could be in the middle of one. They could be about to have one, right? So that doesn't rule out anything. All right, so I did an EKG, all right? The patient's upright. We're going to put on some oxygen. We're going to pop them a nitro. Okay, even though they tried that 3 times and it didn't work, we're going to do it anyway. And then we're going to have them chew aspirin. How many milligrams? 325. We need a big one. Okay. And then we're going to give morphine IV push. Now, why would I do that? They're in pain, but what's the main reason why we give morphine it's a vasodilator to the heart. Okay. That's how morphine decreases your blood pressure. Right. Every time you get opioids, doesn't it lower your blood pressure? Oh, okay then. All right. So we did that. And then you're going to get them into the back. You've got 2 big IVs started, and then you're going to run some massive labs. Yes? Okay. I need to do all my cardiac markers, right? I think I just did this with y'all. Didn't we do that? What did I do cardiac markers for y'all for? I swear we did cardiac markers. Didn't I give y'all a chart with cardiac markers on it?
No.
Oh, maybe that was a different.
On the board. But I think we were just talking about different labs.
No, I swear I just did this. And with who? What group? You're right. That's what it was. My bad. My bad. Y'all haven't learned it yet. Okay. So you've got troponin, CK and B, myoglobin, and then you can do CK, ESR, and CRP. Don't look at your papers. Y'all should know these. All right. What is troponin? What does it tell me? All right. So it tells me that the muscle is dying, and the byproduct of that is troponin. So should you have any troponin in your body? But they do. Okay. So usually rises in about 2 to 3 hours. It's one of the first cardiac related enzymes, like that's specific to cardiac, to rise. Okay. And it will last almost 2 weeks. So this gives me a really good idea of what's going on in the body. Okay. What's the other specific to cardiac enzyme? MB. CKMB. What does that stand for? Creatinine kinase myocardial bands. All right. So there is something called CK. When do we draw CK? Yeah, we've done this a lot. It's a muscle breakdown. So creatinine kinase is an enzyme that appears in your blood whenever you have any kind of muscle breakdown, right? So if you like worked out like balls to the wall, right? Or you just went on a marathon or something, your CK is probably going to be elevated. But CK by itself is not specific to the heart. It just tells me there's muscle breakdown somewhere. But there is a lab called CKMB, myocardial bands, that is specific to the heart muscle breaking down. So those are the 2 cardiac related markers that we're going to use that are specific to cardiac. Yes. What does it stand for? Creatinine kinase myocardial bands. All right, so that's going to rise in about 4 to 6 hours. It peaks at 24, and then it lasts for 3 to 4 days. So we graph those. We're going to graph their markers, and you have to draw serial markers, right? I'm going to draw them over time. And why would I graph them? I need to see what's going up and what's going down, and that will tell me what? Exactly when I had a heart attack, right? Do you understand what I'm saying? Mm-hmm. Okay. Then we're also going to draw myoglobin. Y'all know what myoglobin is? We've talked about it 1,000 times before. What's myoglobin? It's a breakdown of muscle. It's the main byproduct of what disease? Rhabdo, right? So myoglobin is a byproduct or a waste product of muscle breakdown, right? It's not specific to cardiac though, but we're still going to draw it so I can see, right? That will rise in 30 minutes. So that one's actually the first one to rise, but it is not cardiac specific. Okay. So like if the patient was on an MVA or something, their myoglobin may be really high and maybe they have some cardiac related, or maybe they have some chest pain because either they're anxious or I don't know. That can't tell me if they're having a heart attack or not, right? If there's other damage going on. And then you have a CK. We just talked about CK. It's a good one to do, but it's not specific to cardiac. And then y'all know an ESR and CRP. Markers of inflammation, which are gonna have inflammation when your heart muscle is dying. Yes? Okay, but again, not cardiac specific. You with? All right, so they used to say when a patient came in with chest pain to give a Mona. It really should be Onam, okay? Because oxygen really should come first. Then we give nitro, chew an aspirin, give them some morphine. Because you can't just like, as soon as they come in, I don't have an IV. So yeah, I'm gonna toss all the other stuff in their mouth first and then we can start an IV and give them morphine IV push. You with? And then depending on what's going on with your patient, now with MI, they could either have hypertension or they could have hypotension, right? Why would they have hypotension? If I had a patient that was coming in with an MI and I did their blood pressure was 90/60, what would I think is going on? Why? They're going into cardiogenic shock. Very good. Okay, now that's a big issue, right? Or it could be at the beginning of an MI and your body's like and freaking out and you're going into a fight or flight response, right? Or cortisol response too, and you could have hypertension. So it really depends. You got to look at what they give you on a test to determine what you need to do. But if it is hypertension and we need to decrease it, of course, you got beta blockers, ACE inhibitors, ARBs, calcium channel blockers. How long do you have to give TPA? 3 to 4 hours. That's fine too. What is TPA? What does it stand for? Gonna whoop your ass. What the fuck? No.
It's like platelet activation or.
No, it has nothing to do with your platelets. What? This doesn't. What? Help us, Lord. Tissue plasminogen activator. Tissue plasminogen activator. Could y'all give me 1 moment, please? Okay, what did I say?
TPA.
Yeah. All right, so TPA, you have 3 to 4 hour window. It's tissue plasminogen activator. You have a whole big do not give list. Who can you not give it to? Just throw me off at least a couple. Active bleeding. Massively on your period, but even then I probably would. Huh? All right, if you've just had surgery within the last, like 7 days. Yeah, if they're having a hemorrhagic stroke, please do not. Don't do that. Anything else? Big ones? Yeah, if you've had an ischemic stroke within the last 3 months, because chances are you already received TPA, right? Okay, and then there's a whole other list that's like you can or you can't, whatever, you know. All right, so TPA absolute contraindications, or if they've ever had an intracranial hemorrhage. If you've had a brain bleed, you could bleed again, so we shouldn't do that, right? If you have a known cerebral vascular lesion, if you've got an aneurysm, do you want to give somebody something that makes you bleed? No. If you have a brain tumor, because the blood flow to a brain tumor is giant. They make their own blood supply, and then you're like, well, let me make sure that that bleeds out. Okay, yep, we're not going to do that. Ischemic stroke in the last 3 months. If they've had an aortic dissection, if their aorta burst, then don't do that. Nay. Active bleeding, or if they have head or face trauma in the last 3 months, because that means you can bleed, right? Okay, and what are we giving TPA for? It's a clot buster. That's the only one that's a clot buster. Heparin and Coumadin are what? They don't dissolve. They just don't make any more clots. Okay, so they're making sure that your body doesn't make any additional clots and that the clot that you already have doesn't get bigger, but they can't bust up a clot. The only thing that can bust up a clot is TPA, but they're also at high risk of massive hemorrhage if you give it. So you need to be real careful, right? All right, so let's talk about the immediate workup, okay? So patient comes in. I have chest pain. Are you breathing? Yes. Are you sitting up? Cool. Okay, so we're going to put on. Turn your pages over. Okay, so we got a EKG, right? I'm going to have them nitro, aspirin 325, and then I'm like, I need to start an IV, at least one. Okay, we'd ideally like 2 large bore IVs, yes? We're going to start them on some fluids because, okay. And then we gave them some morphine. And then you want to draw some labs. What are you going to draw? All your cardiac markers, right? Okay. I need electrolytes. I need kidney functions. Y'all said we were worried about cardiogenic shock. Yes, we need a liver panel. Okay, come here. We need a liver panel. What else are you gonna do? Y'all should get a CBC probably. Yeah, because if you're gonna give a patient TPA and they have a risk of bleeding, you probably ought to know what their hemoglobin was first. And if their hemoglobin's like 1, then you shouldn't give the TPA. Okay, so that's important to do, yeah? Yeah, we need some coags, because aren't you about to give them heparin and Coumadin once they come out of cardiac cath? Okay, anything else you want to do? Run me through what you already drew. Go. Cardiac markers. Okay, so we can do a CMP, and that will give me my kidney functions, liver functions, electrolytes, and blood sugar. Wham. Okay, so we'll do that. Coags. Good job. Go on. I'm going to draw a D-dimer. Why am I drawing a D-dimer? What is a D-dimer? Well, you're going to learn today. So a D-dimer is a lab test that we will do that tells me if I have a clot somewhere. But it is not cardiac specific. So if you have a clot anywhere, it's going to show up as high. But it's something that we want to look at to see if we have a clot somewhere, because a pulmonary embolism can present with chest pain. So we want to make sure that they don't also have a pulmonary embolism. So D-dimer we almost always use for either DVT or for a pulmonary embolism. But chest pain could literally be like anything, right? So I'm going to work up all the things, right? All right, so here's what we got so far. Troponin, CK and B, myoglobin, and CK. Those are our cardiac markers. We're going to do coags, which would be your PT, PTT, APTT, and your INR, because you're about to start heparin and warfarin. We're going to do a D-dimer to rule out. Okay, we're going to do a CMP. So that's going to give me my electrolytes, kidney functions, liver functions, and blood sugar. I'm going to draw a BNP. What's a BNP? What are y'all saying? Yes, BN. Okay, yes, okay, all right, we're almost there. It is called a brain natriuretic peptide, or they may call it a B-type natriuretic peptide, okay? And what does that tell me? What does a BNP tell me? It tells me a heart muscle. It's an enzyme that's produced when your heart muscle is stretched, not damaged or not like dying, stretched. Do you understand the difference between troponin, which tells me damage? Okay, it's an enzyme that comes out when the heart muscle is dying. Okay, and heart failure is your heart muscle dying. No, but it's being stretched. When it stretches, it releases a BNP. A BNP greater than this number equals heart failure. 100. Where'd you come from? 100. She's all headed. All right. A BNP greater than 100 would tell me they're in heart failure. Now, isn't it possible NMI could cause heart failure? Yes. So that's what we're trying to look at. Do you understand the labs you need to draw? And ERs will have these. They call them rainbow labs, right? They have all the different color tops. And they usually, if you have a nice ER, will take all the tubes that you need and put them together in an elastic, like a, what do you call it? You know, thank you, a rubber band. And then you can just go and grab it. Like it'll just be in a bin and you can grab it, because otherwise you have to look up every single one of these labs. What tops do they need and send them, which is a pain. Okay, we ain't got time for that. All right, do you understand the basics of what to do for an MI? All right, next. You gave the patient TPA. Oh, before you give TPA, what do you have to do for the patient? You're like, hey, we have TPA. I went through the whole list of things, like to make sure that you could have it, right? Because every facility will have a list that you have to check off and get signed saying, I checked the contraindications and they don't have any. Okay. Do you want them to move at all? No. Do you even blink? Okay, because they'll bleed. So probably, yeah, so we're having to go to the bathroom first. We're going to put them on bed rest. If they can't even get up to go to the bathroom, then I'm going to have to put in a Foley, right? I need to make sure I have 2 large bore IVs. We probably should have drawn a... Okay, what happens if they start hemorrhaging? What are y'all going to do? I need a type and cross because I need to know what blood type they are, right? So you probably need a type and cross. There was one other thing I was going to tell y'all, and I lost it. Please hold. Okay, so before you start TPA, bed rest, Foley, 2 large bore IVs, type and cross with what blood that they are. You've checked their coags. Yes? Don't give any blood thinners before you go into cardiac cath either. Y'all know this, right? Okay, all right.
So we do TPA before cardiac cath?
Well, it depends on the doctor. Ideally, we'd like them to go to cardiac cath first because if I gave them TPA, yeah, then they may just bust, you know. But my goal is to get them into cardiac cath within 60 minutes, which means I need to get them to cardiac cath first, and then we'll give TPA. Because TPA, you have to watch them for like 4 hours like a freaking hawk. And I don't want someone digging around in their femoral artery after I give them TPA. Okay. And really, you would only know for sure they need a TPA if you've been in there and being like, we's blocked, right? If you go in there and you're like, it's 100% blockage, we need to bust up that. If it is a clot, it may not even be a clot though, right? It could be just junk, right? And you'll know in a cardiac cath, they can either go in and be like, nope, and come right back out because they're like, I can't even get anything in there. Or they can go in there and be like, oh, we can put in a stent or a balloon because there is enough for me to get in there, right? Those would be your 2 options, okay? Then they can decide from there, can I do TPA to bust up this clot? Or is this clogged and they need a cabbage, right? So that's what the purpose of the cardiac cath is, to go in there and be like, what do we need to do and how do we guide treatment? Okay. All right. So what was I talking about? Oh, TPA. Okay. So we know we put the patient on bed rest, Foley, we checked our coags, we gave them TPA, and then you need to watch meticulously every part of their body for bleeding, right? That means you need to look at all their body fluids. Okay. All right. So let's say we got him in a cardiac cath and they put in a balloon or a stent and then they sent him to ICU. They were in there for 2 days. Everything was looking good. Now you got him on the Med-Surg unit and you're preparing them to go home. Okay, so you've got to do discharge teaching. All right? Okay. What kind of diet do you want to put this patient on? Low salt, high potassium, unless they're on spironolactone or ACE inhibitors, because those cause hyperkalemia too. Low sodium, low fat, and low cholesterol, even though that's not okay. High potassium, and they can do salt substitutes, which that's part of the DASH diet, right? Unless they're on spironolactone or ACE inhibitors, because salt substitutes are made of potassium. Okay. As far as physical activity, we want to get them up as soon as possible because we don't want them to get a DVT. Correct. Okay. So days 1 and 2 in the ICU, they're on bed rest. We're like, don't get up, don't move. I'm going to watch you. That means, yeah, you need TED hose and SCDs and things like that. Days 2 to 5 that they're in the hospital, we want to get them up and they have to be able to ambulate around the hallway in order to go home. You with? Okay. After day 5, we're like, you go home. Bye-bye. And how much do I want them to exercise? 30 minutes a day, at least 5 days a week. Okay. But before they go and do physical activity, they need to check their heart rate. Okay. And they need to have nitro readily available just in case they start exercising. They're like, oh no. Okay. We don't want them to go any more than 20 beats per minute over their resting heart rate when they're exercising, which means basically they can just walk, right? Because if their heart rate goes too high, what does that affect? My cardiac output. Because how do you calculate cardiac output?
Blood pressure plus
What?
stroke volume plus heart rate.
How do you calculate cardiac output?
Heart rate.
Stroke volume times heart rate. So if their heart rate goes too high, it's going to decrease, right, which will decrease, or no, it'll decrease their cardiac output, right? You understand what I'm saying? If the heart rate goes too high, it will decrease the stroke volume, which will decrease their cardiac output, and then they're probably going to pass out during exercise. I don't want that. Okay? Cool. A big thing that patients will ask, especially dudes, is when can I have sex again? And you're like, well, let's talk about it. Have a seat. Okay. So, our advice to them is not to drink any alcohol 3 to 4 hours before sexual activity. Okay. It is a sedative. Okay. It also alters your judgment, Avi. Then you're going to end up taking a nitro and a sildenafil at the same time. Red flag. Okay. So we don't want them to be impaired in any kind of way, and don't eat a ton of food. I mean, if y'all ever tried to do that, like Valentine's Day, that's a recipe for disaster. Y'all go out for a big giant meal and then you're like, it is sexy time and I'm bloated. Thank you. All right. Next, nitro can be used before sexual activity, but not with sildenafil, which is Viagra, because both of those are vasodilators and RAPU. Okay. We do not recommend any anal intercourse if you have had an MI. How come? It'll vasovagal you and your heart rate will tank. And then again, RAPU. And that is a very awkward position to be in. That's call 911. Okay. No hot or cold showers just before or just after. What is that going to do? It affects your blood pressure. So if you're in a hot shower, it'll vasodilate and your blood pressure is going to go way down and then you could pass out, right? If it's a very cold shower, you will vasoconstrict if you already have hypertension because, you know, it's sexy time. That can cause you to have a massive stroke in the shower. So no shower sex either. Okay, that is frowned upon. No sildenafil with nitro. Am I clear? And anything that ends in nafil is the same kind of drug. Okay. And what we'll say is you have to be able to climb 2 flights of stairs without massive chest pain before you can have sex. I mean, these dudes are motivated. Okay. They will be out there at apartments just going up and down the stairs. Okay. All right. Y'all know I've told you since day 1 of everything. If they ever say rehab, we sending them to rehab, right? Cardiac rehab, you going. All right. And then you need to make sure that you teach this is just basic medication teaching. Y'all should already know these. This is a quick, turn the papers over. Hurry up. Don't even try to look at them. Just a minute. All right. How many times can you take nitro sublingual? You can take it 3 times total, at 1 every 5 minutes. You're going to call after the second dose. What can you not take with nitro? Sildenafil. Okay. The prescription for nitroglycerin expires every 6 months. 6 months. I know one of them's 30 days. I think it's rivaroxaban. 6 months, which means it expires. They have to get a new prescription every 6 months. Is it chemically stable? No. So it has to be away from light and heat. Moisture. I can agree with moisture too. Okay. If they're like, oh, I took a nitro and my head hurts, you're going to tell them to take? Because nitro makes your head hurt. I mean, I don't. Yes, acetaminophen or aspirin is fine because headache is expected because it's a vasodilator. Okay. And then you need to teach them patch care if they're on the nitro. Y'all know this one. Hairless area, rotate sides, yada, yada. Okay. Before we give any antihypertensive meds, what assessment do we need to do? Blood pressure. When do you hold antihypertensives? Less than 90/60. What's the one thing you are always going to pick on exams when they're taking antihypertensives? I told you this like 100 times. Huh? Change position slowly. Okay. 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 When are you supposed to have them take diuretics? In the morning, so that they're not up all night peeing. All right, that's just a big crash course. Do we understand MI? What a day.